Good day, everyone. Welcome to PBMI's webcast, Innovation in the Marketplace. I'm Maggie Bruce, your host for today's program. We are pleased to be showcasing 5 programs that represent creative new approaches to managing drug costs and improving employee health. Our first speakers today are Dr. Craig Stern, President of ProPharma Pharmaceutical Consultants, and Danny R. Moriarty, Director of Business Systems Continuous Improvement, hired to retire for Peabody Energy Corporation. Peabody is a member of the Coal Energy Coalition, which collaborated with ProPharma on a quality initiative to improve physician prescribing. I believe Danny's gonna start off. So Craig and Danny, welcome.
Thank you, Maggie. This is Dan Moriarty, and I wanted to just set the table for a little bit of history about why we went through this process. Peabody and several other coal companies decided to get together as a group to address several healthcare-related issues that impacted all of the coal companies. This was in the early 2000s. We all had very rich plans under collectively bargained agreements that allowed for very limited plan design changes. And then we were in very rural areas near the coal fields for the majority of our beneficiaries, and we all had large retiree populations, some of which had their benefits codified in the IRS code under the Coal Miners Retiree Act of 1992. These were very real hard facts and difficult to put in managed care of any type. So we decided to get with a consultant to discuss what our options were, and ultimately we ended up in 2003 coupling up with ProPharma and Dr. Stern's staff about implementing a program to address all of these issues and aimed at lowering our drug cost trends in selected states. We initially had a target of about 2,800 physicians in 2003, but that's grown to over 3,500 physicians in West Virginia, Kentucky, Indiana, Illinois, Wyoming, and South Dakota. Our program focuses on education and data to modify or change primary physician prescribing behavior through direct interaction with these providers. And the conditions that we gave to ProPharma were pretty simple. You can't change the formulary, you can't change the copay structure, and there are no other benefit plan designs allowed under our plans that the coalition members could acquiesce to. So he pretty much had his hands tied. And the task that one of the key tasks was developing a prescribing guide. So that's kind of a bit of the background, and what we've seen from it. The first couple of years, we saw significant increases in generic utilization. We also have had a positive impact on maintaining single-digit trends throughout this period, including being recognized by our FAS 106 actuaries as these programs being an initiative that was considered to reduce our overall trend liabilities. So with that, I'm going to let Dr. Craig take you through a bit about how the program works.
Thank you, Danny, and good afternoon, everyone. I believe that you've heard from Danny the fundamental challenge. Let me just identify, you can't change anything, you can't change benefits, you can't change copays, you can't change formularies, and just to make sure that this is not too easy, the other 2 challenges were make sure that it costs significantly less than $1 PEPM and that the return on investment is better than 1.5 every year. So to make that really easy, what we had to do was to address how do you go about doing that. And our key messages here of the program were that we address this problem as a quality issue in order to try and improve the overall quality of the population, specifically with regard to drugs, but we also dealt with it from a medical side, and increasingly so. The issue was to try and address the difference between national standards for quality and the actual quality measures that were going on in the population. In doing so, as Danny has identified, there is a population in the highest utilization states in the United States, both for drugs as well as for medical services. These states identify that there is a significant trend. The trend each year was a very small single-digit trend last year it was minus 3%, when the minimum expected trend for the particular industry in SIC code was at least 16%. So it addressed the issue of trend, addressed the issue of quality. It was based on trying to manage the performance of each of the physicians, over 3,700 of them, and to manage their variance from the mean. Concentration was based on variance and reducing variance. It focused on managing patient costs. We identified best-in-class physicians through a host of indicators. They were given 5 stars, some of which were quality indicators such as compliance of their overall population, some of which were utilization with regard to coordination of care and removing polypharmacy, and some of which had to deal with cost as to their drug mix and how they approached it. Those best-in-class physicians effectively cost 1/5 of their peers and non-target physicians, as well as used at least half of the number of prescriptions when it was identified. The program itself is based on 3 fundamental legs of the stool. One leg has to deal with education that is done weekly and is general, identifies compelling clinical issues for them to address, as well as evidence-based medicine, comparative costs, comparative issues with regard to various guidelines for care across all the different morbidities. We had to recognize the fact that our physicians were treating patients with multiple comorbidities, so we could not focus on one disease or 2 diseases. This had to be across all diseases that the people treated. The education also included a simplification of their formularies that all of the different coalition members had, at least 6 of them, as well as to deal with the different prescribing that was necessary for prior authorizations within these groups, and then also included continuing education presentations that were done at both the state and their local levels. The second leg of the stool had to deal with using integrated data sets of pharmacy data, medical encounter data, enrollment data, and some workers' comp information to integrate to surgically identify the compelling clinical issues that were on a patient-specific, physician-specific basis in order to create change. They led to quarterly comparisons of a given physician so that they could see what they were doing quarter to quarter in their own practice. They could compare it to their peers on a quarterly basis, as well as to identify best-in-class. This data is across at least 6 different PBMs and at least a half a dozen or more different health plans as we integrate all of the data from the different health plans and pharmacies. The final leg of the stool is educational site visits by educational detailing that brings the local representatives there to talk to them, not about specific drugs, but rather about their variance from care, how did they interpret the reports, and how did they go about coaching and training them to be successful and move towards best-in-class. Every report, every activity has a goal, and in summary, the goal is that education leads to behavior modification. The integrated data sets identify compelling problems and lead to lower variance in care. Feedback on performance with the providers leads to lower inter-physician variance, and then, of course, educational detailing tries to raise the minimum standards of care. The bottom line is decreasing the variance improves quality and utilization, leads to improvement in care, cost of care, and leads to a lower cost trend. Just to give you some examples, the best-in-class and the target physicians were treating similar patient populations with similar diseases, with similar drugs, not surprisingly, because this population has a significant commonality between the different diseases. There was also, as you can see here, trend that started in our benchmark year in 2004 has continued to decrease every year. There has been an element of specialty that was not well recognized at the beginning due to benefit issues. has become increased and now is addressed through specialists. Obviously, the program is not addressed to trying to cure cancer or severe chronic diseases, but is addressed in dealing with those specialists in dealing with coordination of care, quality issues, compliance issues, in order to assist them with managing their patients. Overall, cost of per patient per month stayed relatively flat across the years while it was increasing for the peer group. The numbers of prescriptions that were identified and decreasing across the target group and the best-in-class group, removing and squeezing out polypharmacy and coordination of care issues, decreased while it increased in the non-target group. The drug costs decreased. Generics did increase, as Danny said, but was factored out of all trends so that when the actuaries were validating all numbers on a year-by-year basis, we removed any issues that may be duplicative to what a PBM was doing or otherwise. And we also made movements to improve care in those general chronic populations of cardiovascular disease, diabetes, respiratory, etc. We increased their drug utilization, as well as noticed that drug costs in general tended to decrease because of more judicious use of medications to treat these. We also, to ensure the fact that there was not a shifting of costs to the medical side, we also made sure that physicians were given specific tests that had to be done, not just drug tests, but x-rays, lab tests, etc., in order to be more compliant with national guidelines. This was part of the quality movement that continues. And at the end of the day, best-in-class doctors cost about $55 per patient per month versus the non-target doctors that cost about 5 times that, at about $278 per patient per month. The best-in-class used about half as many prescriptions and identified also in quality that they had improvements in doctors moving from 1-star to 2-star to 3-star to 4-star. These were recognized as well as put in the media when different doctors reached these different levels. The bottom line and the bottom line message of this program is that even in a world where benefits cannot be changed, there is still the opportunity to achieve measurable quality improvement while reaching measurable cost improvement as well as trend improvement, and that can be done by dealing with overall care, overall variance, rather than trying to manage on any particular indicator. We thank you so much for your time, and thanks for allowing us to present.
Thank you, Craig and Danny, and congratulations on being a recipient of the award this year. Again, jot down your questions for them, and you'll see on your screen contact information for Craig.